Aparna, Shilpi, please go ahead with your panel. Yeah. Thank you.
Great. Thank you.
A very good afternoon to all of you, and thank you, ma'am, for having me here today, and thank you, Manjupuri, ma'am, for leading the QI journey as always and encouraging us all to do more and more. We are here together, Shilpi and me, and although ma'am has covered this topic so brilliantly, I think there is hardly anything that we can add. But I think we do have a brilliant panel, with us today. Dr. Swati Sinha from Rainbow Hospital, Dr. Anuradha Singh from LHMC, Dr. Anita Agarwal from East Delhi, Dr. Ritu Sharma from JIMS Noida, Dr. Harvinder from DDU Hospital, and Dr. Vinita Gupta from Baba Saheb Ambedkar Hospital. So we're going to discuss a few aspects of anemia. Essentially, there would be some of the topics that we've already discussed, and we would take it one by one. Before I begin, just a word about the micronutrient discussion that has been happening. Although we would love to have the micronutrients on board, unfortunately, the evidence on consolidated micronutrient supplements is still not available. So I think that is something that we are still going to see. Iron is good, B12 is good, folate is good on its own, but a consolidated micronutrient deficiency is still not evidence-based. So I thought I will just put it out there before we actually take it out, across the table. So I thought I should just mention this before we go on. So I would first invite Shilpi to take the first case on adolescent anemia.
Yeah, thank you, Dr. Aparna. Without wasting any time, I would just highlight on this map, which is depicting the prevalence of anemia in Indian adolescents, where the light pink is a lighter anemia and the dark pink is a severe anemia. So we can see that most of these states are having anemic patients and anemic adolescents. So I'll start with my first case. 15-year-old Tina doesn't want to play with her friends. She feels tired all the time and doesn't eat well. She has an urge to eat clay or chalk at times, and she looks pale. So her mother has taken her to a doctor at Village PHC. And so I would like to ask you, Dr. Swati, how would you prefer to evaluate for anemia? Symptoms are important, or you would go for specific signs and start treatment, or you would first like to have some tests?
Thank you, Dr. Shilpi. At the outset, I would like to wish a very good afternoon and good evening to all the esteemed seniors who are present here and my colleagues. And it's a very interesting topic, and we've had a very great session till now. So regarding this adolescent girl who has visited the PHC, it is very much, we all know that anemia is something that affects not just the physical well-being, but also the emotional and the general well-being of any person. Sorry, can we go? The signs and symptoms are visible that the person is not feeling up to the mark. She's lethargic and exhausted, does not feel like participating in her day-to-day activities. And symptoms in terms of pallor is very visible. Tests, I think in a PHC, the point of care test would be a spot hemoglobin, which is done by looking at the color. It's a non-invasive test. However, if you were to ask, CBC is a gold standard test. Am I audible? Sorry.
Yes.
Sorry. So a CBC would be a gold standard, but I understand that it is not done as the first level in many centers. So spot hemoglobin would be the first line test in a PHC.
Absolutely, as Dr. Swati said. So at a facility which is at a PHC level, we get spot hemoglobin done, which leads to a faster management and faster treatment of the patient. And meanwhile, we can get a detailed evaluation. So Dr. Vinita, would you like to tell us how would you classify anemia? How would you go ahead with the diagnosis of severity of anemia? Do we have Dr. Vinita here?
Dr. Vinita, are you there?
Sorry. Okay. Hi, Shilpi. Hi, Dr. Aparna.
Thank you for having me here, as this is a case of adolescent girl. So according to WHO, the anemia in the adolescent girl is defined as any hemoglobin less than 12 gram%. And as to classify the anemia in adolescent girl, so it is mild, moderate, severe, as the same we have in the pregnant woman. So hemoglobin between 11 to 11.9 is mild anemia. Hemoglobin between 8 to 10.9 is moderate, and between less than 8 gram is severe anemia. And it is important to highlight here that as a gynecologist, we are used to seeing the pregnant woman where the anemia is less than 11 gram%. And as Dr. Manjupuri has already said, we are happy with hemoglobin between 8 to 10, very happy. So especially in adolescent girls, any hemoglobin less than 18 or 8 is almost severe anemia. So we should target of having a hemoglobin of at least 12 in adolescent girl.
Yeah.
It affects their cognitive and the motor development and their school performance also. So it is very important to know what is the anemia in an adolescent girl.
Absolutely. So we can go ahead with the peripheral smear examination as well as the ferritin estimation to tell us about the type of anemia and guide us through the treatment. The various ferritin levels are there to guide us that whether it is an iron deficiency anemia or not. And according to that, the symptoms are also accelerating. So symptoms will help us to know whether she's improving or not. And the ferritin can tell us about the severity. So Dr. Ritu, can you tell us what are the probable causes of anemia in adolescents?
Yeah. Hello. Am I audible?
Yes, yes.
Yeah. Hello. Thank you, Dr. Manjupuri ma'am, Dr. Aparna Sharma ma'am, and Dr. Shilpi for including me in the panel. The probable causes of anemia in adolescents, most common cause is the nutritional itself. They are having the nutritional deficiencies. And second is that in case of the females, if we take the females, then there can be the menstrual problems as well. And also the socioeconomic factors like socioeconomic factors, the dietary factors, they are, I think, the main causes leading to this. Then whether the health facilities which are available, whether they are approachable or not. And I think main reason is the socioeconomic, dietary, and the cultural issues related to the gender discrimination also. And I think these are all the factors.
Absolutely. So keeping all these factors in mind, this is important to, since as we saw in the previous talk, that the analysis of what is the cause is a good directive which can tell us how to treat it. So Dr. Harvinder, can you advise regarding how will you treat her now? Her hemoglobin has come as 8.2 and she's 16-year girl. So
Yeah.
how are we going to go ahead?
Good evening, everyone, and thank you for providing me the opportunity. As this is an adolescent girl with hemoglobin 8.2, so she falls under the category of moderate anemia. So I would like to give a therapeutic dose of iron and folic acid. I would prescribe her 2 doses of blue tablet, which is provided free by the Government of India, each containing 60 milligram of elemental iron along with the 500 microgram of folic acid. I will tell her to take twice a day, at least for 3 months.
Yeah, as we can see in this chart, she has to take for 3 months, and if there's no improvement, she should be referred for a detailed evaluation. And if there is an improvement, then definitely she should continue with a prophylactic treatment. So Dr.
Anita.
Yeah, it's Dr. Anita. So tell me, what is your opinion on deworming? We've already had enough, but a focus on deworming in adolescents. Can you please elaborate?
Good afternoon, everyone, and thanks for giving me this opportunity to be in this panel. We all know that deworming is very important in our country, developing country like us, because we have high prevalence of intestinal elephantiasis. And we also know that it has an inverse relationship with the hemoglobin level. So it has been seen that when we deworm a patient or a girl of adolescent age, their hemoglobin level improves, and various randomized controlled trials have also shown that. So it's very important, and it has, since it has been recognized by our government also, so school deworming programs they have initiated, and they have seen that there is much improvement in hemoglobin level of the children. So it's very important to deworm, and as well as in pregnant ladies also. We recommend that they should be provided with at least one dose of albendazole of 400 mg during second or third trimester. Besides this.
Thank you, Dr. Neeta. So after deworming and giving iron supplementation to this patient, I think there is, as we saw in the causes, what are the causes of anemia in adolescents? So Dr. Anuradha, can you tell us what other advice will you give to this girl?
Hello everyone. I think the very important advice which you give to these adolescents or any reproductive age group female which is coming to us, that the iron tablets are specifically to be taken 1 to 2 hours after their major meals, and the calcium is not to be taken together, especially in case of pregnant women, and they can be taken with vitamin C supplements like normal routine lemon water that can be taken. And of course, we are definitely addicted to caffeine intake or tea intake, especially in the adolescent age group. So after the caffeine or the tea intake, it has to be taken after 1 to 2 hours. Apart from that, the dietary advice has to go hand in hand with the prescription, because that is the most important thing they focus on, like they're being pregnant or they are adolescents. So dietary advice is the most important. Green leafy vegetables, variety of this, which is I think seen on the screen also, and the nuts and the pulses and the jaggery. I think jaggery is one thing which is a most important source of iron and should be advised regularly in diet of adolescent anemia.
Yeah, so okay, iron nutrients and vitamin C. Which another important thing is hygiene. So they have to maintain hygiene, and definitely the prevention of malaria. And in case they are found anemic, they should be identified early and referred.
Yes, that increases the incidence of actually these helminthic infections if they are not maintaining a good food and personal hygiene also. Absolutely. So I think that is the most important thing also highlighted well.
Yes. So after we have seen that there is an intergenerational cycle of anemia. If the adolescent is anemic, they become pregnant, and they become pregnant with anemia, and they give birth to low birth weight babies with low iron reserves. Now we have corrected this girl. She's beautiful and she is going to school now. So I would hand over the panel discussion to Dr. Aparna to moderate the next case.
Yeah, so we now move on to the next case, which is now we have a lady who's pregnant. So she's a 21-year-old and she's primary gravida who's come to the OPD at 4 months, and she's currently like 16 weeks pregnant, and she was advised her routine investigations. So her hemoglobin comes out to be 9 grams. So my question to Dr. Ritu. So my question to Dr. Ritu would be that what will you do next? Do you go for further investigations, like, give all the battery of investigations, or would you like to go for a trial of therapeutic iron? Because, we are such rich in iron deficiency anemia that you would like to treat her first and then go for investigations. What would you do in your practice?
Yeah. Ideally, the patient should be investigated, but considering the high prevalence of iron deficiency anemia in our setting, and also due to the resource limitations or the resource constraints, I think the trial of iron is recommended by WHO as well. And I would prefer to go for the trial of oral iron therapy. Since she is in early gestational age and she is having moderate anemia, I would like to go first with the oral iron, that is 2 tablets per day, containing that elemental iron 60 milligram and folic acid 500 microgram, and that has to be continued. And then I have to follow up the patient. I think first follow-up should be after 1 month with the repeat HB, and if that is improving, then I can continue with the same and till the HB is normal, and thereafter the maintenance dose may be given for the next 3 months. If it is not improving, then I have to reevaluate the patient. And so this oral iron will serve the dual purpose. It will be therapeutic trial also, and it will be diagnostic also.
Right. So thank you, Dr. Ritu. So Dr. Swati, I would like to take this up further with you. So now we have a mixed kind of an audience and mixed kind of a practice, and we have varied population. So yes, ideal is that we investigate, but yes, a diagnostic or a therapeutic trial of iron is a recommendation which has been given by various organizations. So when will you end this therapeutic trial, and what would be the next step in the management? So it's important to mention here that this is an approach in resource limited settings. So just to complete this point here, Dr. Swati.
So yes, in a low resource setting, we would like to do a repeat hemoglobin after giving her iron for about at least a month. But in a resource rich setting, we may repeat it after 15 days to see if we are getting a response to oral iron. If not, then maybe we would like to investigate for other causes of anemia and check for iron stores. If found to be deficient, we can consider giving her parenteral iron.
Yes, so I think that is what. So generally we say that after 1 month of oral iron, and I think this is what we want to say again and again, that once we have given her iron, let's not forget it. We have to repeat a hemoglobin. We have to see whether she's responding, and that's the crux of treatment of anemia, because once we are starting the treatment, we have to make sure that she has responded. So coming to the next point, Dr. Anita, we would like to know that, one cutoff, something that we have to fix it in our minds, that, okay, this is not looking good, this is abnormal, this is normal. So what are the certain things that you would like to, keep us, that we should keep in mind? What are the stages of IDA? What is important in iron deficiency anemia, and what are the normal values?
Yeah, we have, there are 3 stages of iron deficiency anemia. First of all, there is iron depletion. Stores of iron, they get depleted, maybe because of increased demand, less intake, or increased growth demand, bleeding, etc. So this iron depletion of store is not shown in hemoglobin or indices. So they remain normal when this first stage occurs in iron deficiency anemia. Then comes when it is not complete replenited, then comes iron deficiency erythropoiesis. Like in deficient state, hemoglobin production has started. So in this stage, we can find there will be low iron, decreased ferritin, increased iron binding capacity, but still there is no anemia. But in our smear, we can find RBC slightly microcytic still. So already 2 stages of anemia has progressed. But unless we do these things, we won't be able to find out, because hemoglobin till now is normal. Then 3rd stage, still hemoglobin iron supplementation is not done. Full-fledged picture of iron deficiency anemia happens, which results in low hemoglobin, ferritin level, and serum iron, decreased oxygen carrying delivery to the tissue, and iron binding capacity also increases. All the laboratory tests will be abnormal. So these are the 3 stages of iron deficiency anemia. So when anemia happens, all these things, all the parameters, they decrease. MCV, HCV, RDW, everything get
Right,
affected.
right. Thank you, Dr. Anita. So, and why this is important is that because, yes, please.
It's okay. Normal indices, the normal values were like MCH. Various indices are MCV, mean corpuscle volume. It's the volume of the red cells, which is like 82.5 to 98 plus minus. Mean corpuscle hemoglobin concentration is the concentration of hemoglobin in inner red cells, which is around 32 to this is 17 to 32%. And MCHC is the percentage of hemoglobin, which is 32 to 36%. And
Right,
similarly,
right. I think these are the 2, yeah. So these 2 values are something that we should remember. So like we said that, as clinicians, we are not very comfortable reading these numbers. And that's why we are waiting on this slide and, really emphasizing that we have to look at the MCV being between 82 to 98, and if this is less than 80 or more than 100, we know that it is microcytosis or macrocytes. So this is something which becomes important to make a diagnosis. And if the RDW is increased, that means that the anisocytosis is there, more than 13.5, then the anisocytosis is there. So why this is important? Again, the various stages of iron deficiency become important are because this is a slow process which has been happening, and hence prophylaxis also is very important. Iron prophylaxis is important because iron deficiency anemia develops slowly over a period of time. So Dr. Harvinder, just a few more things about trying to understand the diagnosis of anemia and why this becomes very important. So regarding microcytosis, because when we are diagnosing anemia, a peripheral smear becomes very important. So a few things about peripheral smear also which we need to understand as clinicians when we read the smear. So can you tell us about the peripheral smear and the microcytosis of anemia? Dr. Harvinder?
Yeah. Can you hear me? Yeah.
Yes. No.
Peripheral smear is an inexpensive test, but it is a powerful test. It provides so many information. It tells us about the size, shape, and number of the RBC, platelets, as well as WBC. It tells us about whether it is a microcytic anemia or a macrocytic anemia to make the diagnosis clear. And it also tells us about the hyperchromia. And it also tells us about the various inclusion bodies which are present in the cells, RBC, parasites. It tells us about the various type of leukemias. It provides many information we can diagnose on the peripheral smear. Most importantly, the type of anemia on the peripheral smear. If it is a microcytic anemia, then we can have it may be because of the iron deficiency anemia, anemia of chronic disease, then sideroblastic anemia, or thalassemia. So to make the diagnosis clear, it is very important to have a peripheral smear.
Right. So I think peripheral smear is one of the, like Dr. Harvinder said, one of the most powerful investigations and one of the first investigations. But when we have microcytosis, we also have to think about thalassemia, and that is something especially in our part of the country, and that's one of the important reasons why they may not be responding to our treatment. So we have to keep that in mind, that 40% of pregnant women with actually absence of microcytosis does not eliminate the possibility of iron deficiency anemia, because what madam has also been telling is that dimorphic anemia contributes to the absence of microcytosis. So the presence of a concomitant nutritional deficiency of B12 and folate may lead to actually the absence of microcytosis. So we have to rely on a peripheral smear, at the same time do a complete analysis. So now, additionally, now that we are so resource rich, now we're moving from a resource poor to a resource rich setting, we do have the options of additional investigations. Now, do you have a low hemoglobin? So Dr. Anuradha, I want to understand, when would you want the ferritin or additional iron indications? What is the role? When would you want to do it?
See, ferritin is usually indicated in our setup. What we are doing is when we want to diagnose iron deficiency anemia, because this is the first component, or because this is a storage protein basically which is circulating free in the blood and which is carrying that heme component. So it is the most important thing and the first thing to get affected. So when we want to diagnose iron deficiency anemia, or we want to give a parenteral iron, because the side effects associated with parenteral iron sometimes are life-threatening. So a ferritin is a must before we start basically the parenteral iron therapy. And if we want to rule out the other causes of anemia, so ferritin is the most important thing which is to be done in our patients. And when your patient is not responding, see, you have given an oral iron, suppose you are sitting in a health center and you have given an oral iron and on the basis of a spot hemoglobin test. And when your patient is not improving, maybe some other causes, like everyone is saying a micronutrient deficiency or something like that, then we need to do this ferritin test to see whether your patient is responding, number one, and to rule out the other causes.
So thank you, Dr. Anuradha. You told it very clearly that, if we are suspecting, we want to start a parenteral iron therapy, or the patient is not responding to your oral iron, so that becomes like a next level testing. So it's like the next step. So you have microcytosis, you have a peripheral smear, you have the MCB. So you have a diagnosis of iron deficiency, you start them on iron. Not responding, you go to the next level, which is ferritin. But
and ferritin is, the ferritin is actually maybe raised in cases of iron deficiency in certain inflammations or certain
Yes,
hepatic
that's my
disorders.
next question. That's my next question.
Yeah.
So this is where I'm coming in, that, okay, so you say that you are doing ferritin and ferritin is raised, but you are expecting a normal ferritin, right? We are expecting a low ferritin because you are supposed to be having an iron deficient state. So ferritin should be low, but the ferritin is not low. So what are you going to do? Because in the setting of an inflammation, it is falsely elevated. So what are you going to do? So that is my next question to Dr. Ritu, that what is to be done if the serum ferritin levels are indeterminate? Because you are coming from a place where you think that your diagnosis is definitely iron deficiency. You think that, okay, the picture is microcytosis and you have a low MCV, but when you do the ferritin, it is in the level of 31 to 99. So if you have a ferritin which is less than 15, you think it is iron deficiency. More than 100, you rule out that it is not iron deficiency. But when you have an intermediate ferritin, then how do you go about it?
Yeah, as far as this case is concerned, she is a diagnosed case of anemia with microcytosis and with this ferritin, which is almost in the normal range. Then I think I have to rule out other causes of microcytosis like thalassemia. I have to rule out, and for that I can go for the HB electrophoresis, and I can go for a simple test, that is the Manser index. I can calculate that also, and I have to rule out the other causes like the chronic inflammations and other malignancies, which may in these cases also the ferritin level may be normal in that range which you have mentioned. I have to rule out those also.
Right. So here, as Dr. Ritu is saying, so one point is that you probably think of thalassemia because the ferritin is slightly raised and not very high. So a thalassemia minor may not have a very high iron load also. But what I wanted to stress here also is that this is the window where you would want to do the other tests like serum transferrin saturation, TIBC, serum iron. So the entire gamut of your iron studies, this is the place where the role comes. That when you have a confusing serum ferritin in a picture where you are thinking that it is iron deficiency anemia, this is where you want to do the entire gamut of iron studies and not blindly suggest iron studies to everybody. So there is a logic to doing investigations behind iron deficiency anemia in your patients who are having iron deficiency, patients of anemia with iron deficiency. So this is the concept of doing when you have indeterminate ferritin and you suggest further testing. So as we see, if you are having a low ferritin, so you can actually indeterminate ferritin, you can do TIBC and other serum iron and percentage saturation to understand whether it is iron deficiency or not, and then you can go on with your treatment. So Dr. Anita, so when is the other situation when you would look for, okay, now this is not iron deficiency. So what are the other situations in which you would go for other causes?
Yeah, if patient does not respond to iron supplementation within 2 weeks, then you start your investigation, detailed history, clinical examination to rule out other causes for anemia. Could be malabsorption or malignancy, thalassemia, childhood bleeding disorders, or various nutritional deficiencies. So these are the tests which you start performing once your response is not there within 2 weeks, because hemoglobin level starts increasing after 2 weeks.
Right. So you're saying that once patient is not responding, you need to investigate further and look for it. So essentially, if there is macrocytosis, you look for B12 deficiencies. If there is extreme microcytosis, you look for thalassemia. If there is abnormal WBC count, then of course you look for leukemias or some other morphologies. So all of them, then they become the next line testing, and then you proceed further. So, Dr. Harvinder, I think we covered the diet a bit previously on the adolescent anemia, but of course, as Dr. Anuradha already mentioned, all of them become very, very important. Would you like to take something that has not been mentioned by Dr. Anuradha? You think that something has been missed? Pregnancy, diet, anemia, any point that you want to add here?
It is very important that cooking in the iron utensils is also very important to increase the iron supplement. And rest of all is covered by Dr. Anuradha, green leafy vegetable. And if the patient is non-vegetarian, the absorption from the heme part is more. So we can advise her, if she is a non-vegetarian, increase the dose of egg yolk, livers or meat. And I think rest all is covered. जैसे हम initially बोलते थे गुड़, अंकुरित दाल, चना, it should be a routine statement to all the patients, antenatal patient coming to the OPD, increase the good dal, chana with their diet.
Right. So I think the material is a lot. I think all of us will have a lot of material available, but the important thing is to talk to them and take time out of our busy schedules to talk to them about dietary modifications regarding anemia, dietary specifications, and being careful about diet regarding iron.
Yeah,
So,
can I add something? Yeah, we need to actually
Yes.
talk to them about their dietary habits also. What is the routine things which are available in their households? What are they routinely eating? So in that scenario, looking also the economic circumstances of the patient, I think we can advise the diet accordingly. That is the most important thing.
Absolutely. I think we need to be contextual about it and not advise something that they cannot take. So now the next thing is for prophylaxis. Dr. Anuradha, can you just continue on what is your practice and how would you give oral iron for prophylaxis? Like we saw that it is a continuous process and it progresses. So how would you go about it?
See, in pregnancy, because she is a 16 weeks pregnant lady, so oral iron prophylaxis preferably has to start from 16 weeks onwards. It is basically 2 tablets daily, which is to be taken, each containing 60 milligram of elemental iron and 500 microgram of folic acid, which is essential. Minimum of 180 days is required, and that has to continue postpartum. So that is the most essential thing which is important. It just needs to, and it is in our setup, it has to be a continuous therapy. We have to stress upon that because there are a lot of factors which hinders the improvement in hemoglobin. So it has to be a continuous therapy in my setup.
But have you ever considered or given an intermittent therapy as has been recommended?
Yes. Those who do not have a very low hemoglobin, or those who actually have a 12-gram hemoglobin to start, I can advise. If they are not tolerating, we can have something like a alternate day therapy or twice a week therapy if they are not tolerating well. But that basically in cases of places where the prevalence of anemia is not very high, in our setup, I would definitely advise them daily and check for the compliance in the next visit, which is important, whether they're actually taking it or not.
Yes, but I think we should keep this in mind for people who are not accepting and who have a basic good hemoglobin level, that an intermittent iron therapy is also an option. So now coming to this case who had, so if the patient has mild anemia, right? So mild iron deficiency anemia. So Dr. Ritu, how would you treat the mild anemia?
I think, ma'am, it has already been covered in the previous case also. I will start with the oral iron therapy, and the 2 tablets of oral iron will be given per day. And the patient will be followed for the improvement via doing the HbC hemoglobin levels, and after 1 month. And if that is raising, then I have to continue with and the symptoms they are improving, I have to continue with the same treatment till the HbA levels they reach the normal levels, and then I have to give the maintenance dose, continue with the maintenance dose, 1 tablet OD for the next 3 months, and I have to continue it in the postpartum period as well. But if she is not responding, obviously, then I have to reevaluate. And obviously, as previously been discussed, I have to give the dietary advice and deworming in this patient.
Right.
Also.
Right. So thank you, Dr. Ritu. I think most importantly, we need to follow it up with a repeat hemoglobin after 1 month to see the response. I think that is what we forget to do. And we have to see whether she's responding or not. Now, this is one question that is always comes to our mind, whether we can give oral iron in the first trimester. Dr. Swati.
So, as a general practice, we usually do not give oral iron in the first trimester because the safety is not proven. And there, in fact, as per some murine models, it is also said that high iron levels are even toxic to embryogenesis. So, as a routine, we do not like to give oral iron.
But if the patient is anemic, then what would you do? If the patient is anemic in the first trimester, what would you do?
then maybe we can just, after 9 weeks, maybe we can start with oral iron.
Yeah, so actually, first of all, we don't probably need iron in the first trimester because it's not really the requirement is not increased. So it is probably prudent to delay. Practice is mostly avoided due to gastric irritation.
Yeah.
But practically it can be given because most of the guidelines do endorse it because the evidence is not very high on its toxicity. So if it is required, we can give it, generally avoided because of the GI side effects.
Right.
So that's where we stand with the evidence on the iron. So what are the side effects of oral iron? I think this is the toughest question, and this is for you, Dr. Vinita. That I think this is one of the reasons
Dr.
why we are
Aparna,
not
the
able
side
to.
effects of oral iron are not very serious. They are mainly the GI side effects in the form of nausea or upset in the form of
But Dr.
moderate
Vinita, you
diarrhea.
cannot say they are not serious. I think this is one of the biggest reasons why we are
they
still
are the
struggling
most
with anemia.
disturbing side effects actually, because oral side effects in the form of alternating diarrhea or constipation, pain, abdomen are really very disturbing to a day-to-day life of a patient. But they can be tackled by good counseling and advice to take the oral iron after at least 1 hour after the meal. That is the one very good strategy. But if at all the symptoms are still not controlled, then the other options are that they think is to take the iron tablet at the bedtime, because at that time the majority of the symptoms the patient falls asleep, and then it is not disturbing. The other thing is that it can, if still they are not controlled, they can be advised regarding the stoppage of the iron therapy for some time and then restarting the therapy with a small dose after 3 to 5 days or 5 to 7 days. And if still not controlled, then it is better to change the salt of the iron, oral iron therapy. So they are the 4 main modalities of the treatment of the side effects.
Right. So like you said, intermittent you can do, content you can decrease, or changing to an alternative preparation, taking with meals, or maybe taking at bedtime.
Majority of the time, the counseling is the one which helps to overcome the side effects. You do the good counseling, you tell the benefits of taking it rather than avoiding the side effects. They will start tolerating the oral iron. That is what I
can I make a comment? Actually, in my setup, I have seen that majority of the patients won't even tell you the side effects. They just have a low hemoglobin, and on repeated questioning, they will say, okay, mere ko to thoda sa intolerance hai ya kuch hai. It is that way. Then you need to ask about it, because majority of the patients will not tell.
Yeah.
That's very true. Shilpi, you would like to take this case up?
Yeah, so we come to the next case. She's a third gravida para 2 living to a rural woman with twin pregnancy. She comes at an advanced gestation with a hemoglobin of 8.5. So she's taken oral iron, which is given to her. And on investigations, she's found microcytic hypochromic iron deficiency anemia. So now how do we deal with this patient? Dr. Anita?
Yeah. Since she is in her last trimester, and hemoglobin she is having moderate anemia. So next is we can go ahead with the parenteral iron. So parenteral iron can be given either intramuscularly or intravenous. Earlier we used to, in our setting, we used to give intramuscular iron, but it has lots of side effects and sensitivity reactions. So nowadays we give IV iron. So just a word about intramuscular iron, and before giving parenteral iron, we must reconfirm the iron deficiency by checking, so that she should not be thalassaemic. It should be a good facility where one can monitor the patient, and we should have ready drugs for in case of any anaphylactic reactions. So and someone to supervise the iron infusion in whatever way. So the side effects of intramuscular iron is repeated injections. They can cause itching, discoloration, arthralgia, and joint pains, which is very, very common in such patients. Lymphadenopathy, etc. So this is the side effects. And one more important thing is that we should stop oral iron before proceeding parenteral iron, minimum at least 24 hours, so that to avoid the toxic reaction. And IV iron sucrose is very good, and we give right and left because it has minimal side effects and minimal hypersensitivity reactions. And within 15-20 minutes, it can be given in any setting when some doctor is available. And it is not time consuming, and it causes rapid rise in hemoglobin level. And as well as stores of the iron stores are very much improved by the time she is going to deliver.
Absolutely. So, but we also have to keep the number of visits in our mind, whether the patient is staying nearby and she can come over, because with the COVID making us stagger our admissions, we have to think about whether we have to give iron sucrose or carboxy maltose. So, Dr. Harvinder, what parenteral iron would you prefer in your hospital, and whether they are available?
I would like to give, we have two parenteral preparations available, iron sucrose and ferric carboxy maltose. And we are using both now. Recently, we have in the government setup, the FCM is also available. And I would like to give FCM to this patient because of the better compliance. As the single dose is required, we can give 1,000 milligram in a single dose to be dissolved in 200 ml of normal saline and infused over 15 to 20 minutes. And a maximum of 1,000 milligram is given in a single sitting in a week. Then if another dose is required, we can give in a second week. But in case of iron sucrose, maximum dose of can be given is 600 milligram in a week. 200 milligram of dissolved in 200 ml of normal saline is given in a day. Alternate day, we can give 3 doses. A maximum of 600 milligram can be given. I have recently done a thesis with FCM on a patient of 100 patient, which I have seen the rise of hemoglobin is better with FCM along with the better compliance. And the side effects are almost same in both the preparations. So I would like to go with FCM.
Yeah, we recently had a study from AIIMS also by Dr. JB Sharma. I don't remember exactly, but that was a controlled trial and it also proved the same. So we are also following the same, but iron sucrose is definitely more in practice, and the dose can be calculated by the Ganzini's formula. So Dr. Anuradha, can you tell us what is the management after the total dose of iron is being administered?
Yeah, for oral iron, basically after the total dose is over and we feel that the hemoglobin has come up to the desired level, we need to give it additionally for 3 to 4 months to build up the stores. But that is not the case of parenteral iron. It is said that in parenteral iron, if your desired hemoglobin is somewhere around 12 gram%, then you need not give the further dosing if your hemoglobin stays at that level. You need not, because that builds up the stores also. So that is the additional advantage with parenteral iron.
So after the parenteral iron, we come to the case number 3, Dr. Aparna ma'am.
Yeah, so here now we come to this case in which this is the report of the patient in which the hemoglobin is 8.5. She is now at 24 weeks of pregnancy. Now we see here that she has dimorphic anemia, where she has anisocytosis with a dimorphic anemia. So we continued her investigations and we saw that she, although with the low serum iron, and she has TIBC which is increased, transferrin saturation which is decreased, serum B12 is also decreased, and the folate levels. So essentially we have a situation where we have both nutritional deficiency of iron and folate, iron and B12. So this is iron deficiency with megaloblastic anemia. So before we go on to the megaloblastic part, I would just like to ask from Dr. Vinita. Now this is a mid-gestation moderate iron deficiency anemia.
Yeah.
So for what will you do for the iron deficiency anemia? This is mid-gestation with iron deficiency anemia, moderate.
Yeah. Dr. Aparna, it is mid-gestation iron deficiency anemia. So I would like to go for the oral iron therapy, starting with 60 milligram of elemental iron twice a day, along with the folic acid, 5 milligram, because it is a megaloblastic anemia. So dimorphic. So we have to increase the dose of folic acid. So till the anemia is corrected, and I would like to do the repeat investigation of the hemoglobin after 1 month, along with vitamin B12, that is 1000 micrograms single dose IM, followed by 1000 milligram daily till the anemia is corrected. So that is how we go.
Right. So I think Dr. Ritu, can you also add on to it? Like, what would you like to do? So I think the dosing, I think ma'am said that they have tried a single dose of B12, but what we traditionally talk about is, Dr. Ritu, would you like to also talk about the dosing of B12?
Yeah, ma'am, B12 parenteral dose, we usually are giving it as 1000 microgram per day for 7 days. Then it is followed by weekly. Then it is followed monthly thereafter. This is the usual practice we are we are following. And also we can give it on alternate day basis also. That is thrice a week. Dose can also be followed. Yeah.
Right.
Dr. Aparna, I think 1000 micrograms IM single shot followed by 1000 micrograms per day orally is as good.
There are varied protocols for that.
Yeah.
Like here it is prescribed once per week till it is corrected, then per month. And we are also giving orally, in fact. So we give it orally once per day. So I think those protocols are also there. So there are multiple things. And like ma'am said that they have tried giving it a single shot of 1000 microgram. So I think there are various protocols which are available. But the idea is that this is a very crucial element of deficiency, which can cause refractory iron deficiency anemia. In fact, worsening iron deficiency anemia despite the iron supplementation, and needs to be kept in mind at all times. And what about folate deficiency? Dr. Ritu, you can just cut. So, yeah.
Ma'am, as far as folate deficiency is concerned, the therapeutic dose varies from 1 to 5 milligram. Usually we are giving it 5 milligram per day oral dose. And it is to be continued postpartum. In the postpartum period also, it is to be continued for 4 weeks postpartum. And along with this folate deficiency, we can add the supplement. We can supplement it with the B12 prescription also. And as you were already previously discussing regarding the oral and the parenteral therapy of B12, I would like to emphasize that the recent that Cochrane review has failed to demonstrate the equivalence of that this oral therapy as compared to the intramuscular, that is the parenteral therapy. But maybe it may be due to the lack of the good quality these studies. And but the advantages of this injectable therapy, I think they are more. That is, there is the dosing is not frequent, and also this improved compliance is there. And there are no GI side effects also. Yeah.
Right. So I think that is about. So Dr. Harvinder, how do you assess the response to therapy? And I think it is common for all of the anemias, whether it is iron deficiency or whether it is B12 and folate deficiency. How to assess the response?
The first most important, the symptom it relieved is sense of well-being. The patient always says after 5 days कि मुझे अच्छा लगने लगा है. The sense of well-being is the most important symptom to get relieved. After that, there is a rise in the retic count. We can see the rise in retic count after 6 to 7 days. The maximum rise can be seen up to 4%. Then after that, we can see the rise in the hemoglobin. Hemoglobin levels start rising after 2 to 3 weeks by the 1 gram per deciliter per week. And then after then the stores get replenished. We see the improvement in the MCV, MCH, and the ferritin levels.
Right. So I think very important that we keep monitoring the patient for the response, and to see whether our patient is responding or not, and take corrective measures in time. So now this is the last case that we wanted to talk about, and the importance of looking at the complete picture of CBC to interpret it nicely. So here we have a picture where we have a hemogram which is 7 gram %, MCV which is 58, MCH which is 16.7, RBC count is 4.18. Now, in our routine practice, how many times do we actually look at the RBC count? It's a very easy thing here. So if you look at this picture here, the RBC count is very well mentioned here in all of our CBCs. And here it is shown as 4.18, if I can be very clear. Now, Menser index is something which we can easily calculate by dividing the MCV divided by the RBC count. So 58 divided by 4.8. So something to really, a simple calculation which we can do in our day-to-day life. So in this particular case, on further investigations, we found that the serum ferritin was 3.6. So she also had iron deficiency anemia. Her TIBC was 442. Her husband HPLC was normal. So I would just like Dr. Swati to discuss what is the diagnosis here, and is this very common in our situation?
As we have seen, I think the HPLC for the woman has been done, and that shows thalassemia minor. So this looks like a case of thalassemia minor with iron deficiency anemia, which is also a very common condition. People are not aware of their thalassemia status. And the HbA2 is usually more than 3.5, that is diagnostic of thalassemia minor. So that is and many times it is associated along with iron deficiency. So by giving oral iron supplementation, their hemoglobin improves considerably compared to what it is at the moment. It can reach to a maximum of 9.5, 10, 10.5. That is what we are looking at in a thalassemic woman.
Right. So this is why we have highlighted this report here, is that this is a very simple report. It can be read by each and every one of us, that when we have microcytosis, if we can simply look at these indices, Menser index, and we see that, okay, the RBC count is increased, then probably we start suspecting and do HPLC. Although if we are not a resource poor setting, we now recommend HPLC for everybody in the thalassemia belt, because India is the thalassemia belt, is within the thalassemia belt of the world. So I would like to know from Dr. Anita that is there a simple screening test for thalassemia that can be used on a large scale? Dr. Anita, you there? Or anybody else? Dr. Anita, are you there?
Yeah, I'm here. Yes, I'm audible now.
Yes, you are.
Yeah, we have a single rapid, simple cost-effective test, which is called NASTROF, means naked eye single tube red cell osmotic fragility test, which is a simple test, and based on the principle that these cells, microcytic cells, have reduced osmotic fragility when they are put in hypotonic saline 0.36, and they lyse quickly, otherwise they restore. So this is a simple test which we can do to detect NASTROF, and singly this test has almost 96% sensitivity. And if we combine it with our MCV, and which is less than this thing, so it is quite effective, and we can do that on large scale. We can go with this test.
Right. So thank you, ma'am. So I think this is a very important point that we have brought up here, that, again, it's a fact about low resource setting and a resource rich setting. If we have the means, let us do HPLC for all. But if we don't, then a lot of public hospitals, even in Delhi, they do offer NASTROF test for everybody. So this is in our own benefit, in the benefit of the patient, that we offer some kind of thalassemia screening to everyone. And I think it could be a matter of debate to a lot of people, but HPLC screening is desirable. It is desirable by all means that we do. So you see the Menser index, if the MCHC divided by the RBC count, if the RBC count is high, we know it's thalassemia. So the Menser index is going to be low. So if it is less than 13, it is suspicious of thalassemia. So to make a diagnosis, so Dr. Ritu, would you like to just talk about some basic values? So the idea is that we go back with some number in the mind that, okay, if this is more than this, this is thalassemia.
Can I add something on this, please?
Yes, please.
Yes. Yeah. If there is a severe microcytosis, I think that also hints towards thalassemia. That is looking at the CBC report. One is Menser index, which you have mentioned, and one is MCV less than 60. I think severe microcytosis also points towards thalassemia.
Very, very good point. And I think this point came up in the earlier slide when we discussed that when would you like to additionally test for some additional conditions, and severe microcytosis was one of the features. So we should be aware of certain, indices in the CBC. When you have those, a raised RBC count of more than 4 lakhs, or severe microcytosis, all of these are indicators that microcytosis is probably because of something else and not just iron deficiency anemia. So Ritu.
Yeah, for definitive diagnosis of thalassemia, I would like to go with that HB electrophoresis, and which works on the principle that there are the charged hemoglobins, they migrate at a variable rate in an electric field, and depending upon that, we can identify various types of that hemoglobin, and we can also assess their quantities as well. And depending upon the type and their level, we can identify different conditions. For example, the normal HB, the normal adult hemoglobin level ranges from 95 to 98, the minor adult from 2 to 5, and then the hemoglobin F from that, I think, 0.5 to 2%. And if they are in the normal range, then we rule out this thalassemia. But if there is they are raised, any one of them is raised, accordingly we can identify the type of thalassemia. For example, if hemoglobin F is raised, we can say that this is the beta thalassemia. Hemoglobin A2 is raised, minor beta thalassemia, and so on. There can be other type of hemoglobins also, like the hemoglobin C, S, E, and yeah. So depending upon that, we can find out the cause of that.
Right. So the only thing that we need to remember here is that the HbA2 values, till the time that they are less than 3.5, we are happy. It's normal. But if the HbA2 is between 3.5 to 3.9, there could be thalassemia, and we need to start thinking about it. Because if it is with IDA, then it can be with beta thalassemia. With IDA, you can have values between 3.5 to 3.9. But the moment it is more than 3.9, you know that there is beta thalassemia trait. And more than 9, of course, there is a problem. But between more than 3.9, you know that it's a thalassemia, beta thalassemia minor or a trait. But 3.5 to 3.9, you can be having it if there is associated iron deficiency anemia. But less than 3.5, you're okay. So some basic numbers or understanding of HbA2, all of us should know. And if you look at the graph, it looks like this. The HbA2 comes here. The HbA is something that is the largest peak that it is forming, and these are the minor hemoglobins that they are showing. So HbF, HbA2, and HbA. So this is how the report will show. Now, so Dr. Harvinder, when should you actually do a hemoglobin electrophoresis? What are the conditions that you would ask for a hemoglobin electrophoresis? I would say ask in all. I would say that
ideally it should be done in every antenatal patient. According to me, it should be done.
But there might be people who would say that, okay, it is debatable. So I would say like the theoretical question. But yes, which are the conditions?
It should be done in patients who have a history of consanguineous marriage, especially. Then if the iron deficiency is not responding to, with oral iron treatment, microcytic anemia is if not responding to the iron. Then if there is history of hemoglobinopathies, hemolytic anemias, it should be done. At least electrophoresis should be done to rule out these.
Yeah. So generally, if there is a baby with hydrops, or there is some previously hydrops fetalis, right? Or there is some sickle cell, suggestive of sickle cell, in all of these situations, you will definitely do it, right? So this is something that you should definitely ask for this particular test, right? Now, I think that is all, because we are exactly on time and we finished in 1 hour. So I think we tried to cover all. Shilpi, would you like to, say something? And I would say that, we'll just take one comment each from our panelists, because this is something that is a topic which is very close to our heart. So Shilpi, starting from you, we can just take one comment from our panelists.
Can you stop sharing?
Yes, ma'am.
Yeah, thank you, Dr. Parna. I think the key points we have already discussed, and after a approach-based, the reason-based approach to to eradicate anemia, first is knowing the cause, deworming, then iron supplementation and diet is the thing take home message.
Yeah. Dr. Vinita?
Yes. Yes, Dr. Aparna.
Yeah, just one word to conclude, one comment from you to conclude the panel.
Yeah, Dr. Aparna, it was a very nice panel, and all the points were well covered. And the carry-home message is also very clear, especially about the vitamin B12 supplementation, which is always a doubtful area in majority of the, especially the government hospitals. The private practitioners might be giving it, very as a routine, but in the government hospital, it is not being routinely given. So I think this is the best carry-home message for me, especially, and all the government places, people, that we will start giving this iron vitamin B12. Number 2 is that, yes, we will start screening for the adolescent anemia also coming to our OPD, especially those PCOS patients, those girls, AUB patients. We are doing the CBC for the anemics with AUB, but not for the all PCOS patients. So I think we will start doing that also. These are the 2 important carry-home
Right.
messages.
Thank you. Dr. Swati?
Can we have 5 minutes video in the end?
Swati is left.
Malti?
Dr. Swati?
Swati is left, Aparna.
Okay, Dr. Ritu?
Yeah.
And Dr. Yeah.
Yeah, ma'am. Yeah, I would like to say, rather emphasize that our goal is to reduce the prevalence of anemia, and the evidence-based medicine may not be, we may not be able to implement it everywhere because of the low resource settings. And so what I have learned today is that we have to go for the oral iron trial. That should be I think encouraged at every level.
Right. Dr. Harvinder?
I think the most important thing is we should spend at least 5 minutes with the patient to counsel her, listen to the problem, why she is not taking the iron, and give her the dietary advice. That should be, at least we are prescribing, we are writing, but we are not listening to the patient's problem, why she is not taking. We should spend 5 minutes with the patient and counsel her.
Right, right. Dr. Anuradha?
Yeah, 3 points from my side. Always have your antennas up with anything less than 12. Don't get satisfied with 10, 11, 8, 9. I think anything less than 12, you should have your antennas up, number 1. Number 2, don't forget the vitamin B12 part, because every second or third patient is vitamin B12 deficient. And don't forget the social factors. Like Dr. Harvinder has emphasized, spend at least 3 to 4 minutes and ask why she is not taking iron, or what is the actual cause. We keep on prescribing, and we are not talking to the patient. Even in our setup, where we have a OPD of something like 400 patients per day on Monday, I think if I spend 3 to 4 minutes, that is good enough. Thank you so much.
Yeah, thank you. So thank you everyone, and I thank the organizers, Sharda Jain ma'am, DGF, family.